In Uganda, close to 1.2 million people are living positively with HIV and AIDS. This number is expected to increase because of the need to keep them alive. The Infectious Disease Institute over the years has maintained 200,000 Ugandans alive through offering right information about HIV and AIDS in their programs. Much emphasis has been put on prevention through providing pre-exposure prophylaxis, research on clinical trials, and have now moved to injectable antiretroviral drugs. One of the biggest things that needs to be done is knowing the changes in the community and adapting messages that advocates for HIV and AIDS prevention.
This should be supported to test 95%. We need to have 95% of people tested. And those tested, we need to be linked and 95% of them, and also 95% of patients are linked and on treatment suppressed. In other words, that majority of us suppressed. So one of the key challenges has been adapting. Now we are many years down the road, so we have to change with the times.
Previous studies have shown a downward curve on HIV and AIDS spread in schools and higher institutions of learning, but an increase has been registered in the spread of other sexually transmitted diseases, STDs, which is attributed to high-risk behaviors, substance abuse and prostitution in higher institutions of learning.
Dynamic social life can be a risk in those aspects because, you know, if you will take alcohol, if you'll get excited, if you'll meet, doesn't mean any. You see, when you see a low prevalence population, you don't neglect them. You focus on them.
Of them in universities, but even we go down as low as secondary schools, as you can imagine. You know, in this country, people start having sex around, 14, 13? It's a worrying trend because, you know, teenage pregnancies during COVID, all that tell you something. That's where we should actually focus. By the time you reach university, you may be already in a different place.
Students who come here when they are 18, and so people who are still 18 to around 25 are still struggling with those teen adolescent issues. So the risk behaviors come up because they are finding independence for the first time, and therefore they are misusing this independence, and they are mixing. Each is coming from a different background, a different school, a different family.
Country where we are, children are having sex, but parents, religious leaders, or their caregivers are really failing to appreciate the same. That means that they're not giving them the relevant information that they need to protect themselves from contracting HIV. But also that means that when they contract HIV, they're not in position to disclose to them for support. So they live in denial, they live in...
Makerere University established a counseling and guidance center to address students' psychological needs, although the main place to handle students seeking HIV and AIDS services is the university hospital. Evelyn Karono Lufafa, a counseling psychologist, says many of the students get the services from the university hospital.
From here say is that, yes, the number of cases that go to use the services are quite many because, why? When the counselors who deal with these children, or even us, sometimes when you ask us as a child or a student that how many sexual partners do you have or something, someone can tell you I have 4. There's a lot of casual sex among university students, whereby people don't have to really take time to know each other. And so
students at Makerere University shared their opinions with us about campus lifestyle that often exposes them to risk of contracting HIV and AIDS.
Being involved in such, they are most of the times involved in drug use and alcoholism. So by the time they get involved in acts like sexual intercourse, they don't take caution to prevent themselves or protect themselves in any way.
It is for those who are not conscious, because there are those who are living a risky or an experimental lifestyle when they are not conscious or not protected, and those that are at least somehow conscious.
So far, I think I've not practiced that stuff. So I'm still abstaining. But for anyone who is willing, or if I've told them to do it, I prefer using protection.
Besides the services rendered in the prevention of HIV and AIDS in communities, messages have been tailored on emphasizing prevention like abstinence, be faithful and use a condom strategy. However, Dr. Semere says the messages have not had a big impact on the vulnerable community, a matter he attributes to changing generations.
Part of what happens even at university, that I'm free, I have money. Now, dealing with that behavioral environment needs expertise, social behavior expertise. Someone has to actually dig into a bit. There's something deeper there that we have to understand. I know of some programs or grants that are actually looking at sexual behavioral health around HIV at Makerere itself, and they're digging into some of these nitty-gritty, of especially around prevention. And so it's a bit of a gap, but it's also a changing dynamic.
Evelyn Karono says what exposes the young people between the ages of 18 to 25 who join university to engage in risky behaviors is inadequate information on sexual and reproductive health. While Ruth Awor from Uganda Network of Young People Living with HIV and AIDS holds a contrary view of people thinking that the teens hardly engage in sexual activities.
We need a lot of campaigns in the university, whether in the halls of residence, in lecture rooms, either messages that are just speaking trees or, speaking walls or, on social media to raise awareness of sex and reproduction health, because this is where the issue is. There's be a lot of information giving about safer behaviors and safer sex and knowing their rights.
Do we have systems where they can go for psychosocial support? Do they have a counselor they can speak to about issues that affect their well-being, about their mental health? But also when they need to go out for treatment, do we have avenues that they can secure permissions to go for their clinical checkups and appointments on time?
Whereas the other bulk of HIV and AIDS cases are transmitted through mother to child, the Executive Director, Uganda Network of Youth Living with HIV and AIDS, Ruth Awori, says the biggest challenge is with the children not adhering to treatment when they grow and start going to school.
Instruct one to take medicine, go take medicine, or even you administer it yourself. But when they reach a school-going age and they have to go out of the control of their parents, then it becomes a challenge, because then that requires a parent to disclose to the child their HIV status so that they can know why they are taking the treatment. In situations where the children do not know why they're taking the medicine, that's why you find that they're actually not taking their medicine very well when they're not under the care of their parents, and they end up having viral load, very high viral loads, and you find that sometimes even this translates into drug resistance.
Dr. Semere appeals to the youth to stick to prevention as opposed to treating, which often comes with expensive cost burden, not affordable to many.
But right now, partly when I talk about it, it's abstract. It's very abstract. I don't feel it. Even if I knew someone is, it may be hard for me to perceive. Generation, you say, okay, yes, HIV is not a death sentence, but you are going to have to take a tablet all your life. Is that what you want to do? And, we have to draw blood on you, we have to do this monitoring. It's not bad, but it's a cost. And if if you can, keep away.
The biggest challenge encountered by medical experts in maintaining HIV and AIDS patients on treatment is patients reporting for treatment when they are in advanced stages of their CD4 count. This is attributed to society discrimination that causes stigma among the HIV and AIDS patients. I'm Nafka Farida and Juman Samba in Kampala.